conference is on osteoporosis. This was actually a talk I had planned literally right the week that we stopped doing these for COVID. So it was kind of held on to until now. So I thought we would just kind of go over not just osteoporosis. There were some board questions, actually. This was brought up because some of the in-training exam questions, there were a few missed by a larger number of residents. So Jen and the committee kind of looked at what were topics we needed to go over. So this was one of them that was one that we thought we'd go over. So I'm gonna go ahead and start here. So I think we all recognize that osteoporosis is fairly prevalent, but what's happening is we're seeing that the increase between 2010 and 2030 is pretty significant, not just in people with actual diagnosis of osteoporosis, but also just low bone mass. So I think it's something that we're going to see in our practice fairly regularly, and just want to make sure that we are kind of paying attention for it and screening for it. If you look at the distribution of patients that have osteoporosis, you will see that Mexican Americans actually have a higher level of it than both non-Hispanic whites and non-Hispanic blacks. So something to also pay attention if you're seeing a larger proportion of them in your practice. And definitely females over men typically, but you will see, I think one thing coming out of this is making sure you are thinking of osteoporosis in your male population too. The impact of the disease, it's kind of astounding how many people around the world actually have it and how many will suffer an osteoporotic fracture. So they say globally 1 in 3 women and 1 in 5 men will suffer an osteoporotic fracture over the age of 50. And so that's something that's really important to think about, and that we are seeing 1 fracture every 3 seconds around the world, which is kind of crazy. And the increase is really large in the number of hip fractures we're going to see by 2050. So again, this is a topic that's probably going to be something we deal with even more moving forward in our medical practice. Risk factors. So this was a nice table I got from an article in the journal Family Medicine that listed the primary risk factors as well as some secondary risk factors. I think most of us are very aware of the top 3, both female and someone who's getting older, as well as someone who's more petite or small body weight. But anyone who's got a family history, so a parent that had a hip fracture, we should be aware of. We'll talk more about steroid treatment. So people that are on long-term steroid treatment definitely are at higher risk. Our smokers are going to be higher risk, and anyone who drinks alcohol regularly is going to be higher risk. And then we've got a bunch of other conditions. The one I wanted to bring about is COPD, because I do think we see quite a bit of COPD in our patient population, and most of them, a lot of them are female and small build. And so we need to think about all of those risk factors as something to really make sure that we're doing appropriate screening. There are some other kind of risk factors that are more kind of broken down by both lifestyle, medication, some genetics, and then other disease states. Again, this kind of represents some of what was on the other table, but a couple things here on this table that I wanted to bring everyone's attention to is the use of SSRIs. I think that's something that we use fairly frequently in our patient population, as well as Lasix and omeprazole and steroids. So those are things that we need to be thinking about. If those are patients that are on long-term use of those meds, we probably need to make sure that we're thinking about, do they have other risk factors for osteoporosis and should they be screened? And then down here, again, most of those same conditions that we just talked about. Mute someone, sorry. I have control. But most of the time we are thinking those things, but I don't think we're always thinking about bone density in some of those populations. Okay, let me go to the next slide here. Maybe. There we go. One of the things that when I was reviewing for this talk that makes me realize that I may not be doing a thorough job of this is just when I'm dealing with patients with rheumatoid rheumatological conditions that can increase the risk of osteoporosis, am I doing appropriate screening for them? And so those patients include rheumatoid arthritis, ankylosing spondyloarthritis, SLE, systemic sclerosis, PMR, and then giant cell arteritis. So again, I think one of the points that the article I read, drove home is that just honestly, it's a lot of times linked to the fact that these people are on long-term use of steroids, and they're possibly less active. So that would be possibly why, but something to consider and make sure whether it's the rheumatology doctor doing that screening or us, we need to make sure it's getting done. So what are the screening guidelines currently? USPSTF recommends that all women age 65 and older should be screened routinely, and that's a grade B recommendation. And then they also recommend that women greater than 60 with increased risk for osteoporosis should be offered screening. So some of those conditions and situations that we just brought up would be a reason to offer screening at that age. Currently, unfortunately, there's no sufficient evidence to recommend screening in men. So we definitely want to still consider the risk factors, but there's nothing that says we would routinely screen them. ACOG follows this pretty well. They, as above, say age 65, and you need just one risk factor for osteoporosis to be screened. And so again, they would indicate early screening if need be. One consideration or one thing that I wanted to bring up is what exactly does screening involve? And what I read multiple times is that the screening really should involve that we assess their risk factors and we get a measurement of their bone density. And so again, that's something that I can do a better job of with my patient population, is really doing a true risk assessment. And so I wanted to show you guys how to use this FRAX tool, risk assessment. If you've used it before, it's pretty cool. But I have a kind of fake patient we'll go through, and so I'm going to bring that up. And it's pretty easy to get to. You can just Google FRAX, and it will come up. And so I've created kind of a patient here that we'll put in. And everything's already populating since I kind of did this. I liked the number 58, as you can see. I don't know how that actually all worked out, but then I really liked that it did. So for her, she has not had a previous fracture, so I'd say no. But I am going to say that a parent had a fractured hip. I am going to say she's a smoker. I'll say that she's not been on long-term glucocorticoids. She doesn't have rheumatoid. And she doesn't have any secondary osteoporosis, and doesn't drink more than 3 units of alcohol per day. So then you calculate, and when you do that, so if I don't know her bone mineral density, so she's in my office, and I've not sent her for DEXA, you can do a calculation without the BMD. And if you do that, her risk for a major osteoporotic fracture in the next 10 years is 17%, and her hip fracture risk would be 2%. And what's nice about this tool is if you come down here, you can kind of look at what their recommendations are. And for her, she wouldn't really meet the recommendations right at this moment to be on any bisphosphonates or any meds, because their recommendation is anyone with a 10-year probability of hip fracture greater than 3% or a 10-year probability of a major osteoporotic fracture greater than 20%. However, if we send her for her DEXA, which hopefully we do, and we're going to put in a T-score for her, and we're going to say okay, and we're going to say she actually is minus 2.4, so she's not quite in that what the definition, and we'll talk about this in a second, of osteoporosis is, but she's right under it. So if we do that, we're going to recalculate. And now if you can see, that's recalculated, and she does actually, even with a 2.4, so she's considered osteopenic by T-score definition, but with her risk factors, she is considered at risk and would benefit from a bisphosphonate. So something to consider is using this calculator both pre and post DEXA. And you can input this information into your note so that you can then say, calculated 10-year risk for fracture to be at 21% and hip fracture to be at 3.8 would qualify for bisphosphonate. So I think it's an easy tool to use, and definitely something that we should all try to do a little bit better job of. I know myself included. I actually did this yesterday with a patient. So so it's trying to use what we learn is great. So let me close this out. And kind of to know a little bit more about like when would we be doing a bone density scan. There is a International Society for Clinical Densitometry that has indications for when to do a bone density. And again, it follows a lot of what we're seeing for what the recommendations are for screening, which is women age 65 and older. And then for postmenopausal women that are younger than 65, if they have any of these risk factors, then there would be a reason to do a DEXA. So low body weight, prior fracture, a high-risk med use, which we talked about those, a disease or condition associated with bone loss, women during that menopausal transition with clinical risk factors. And so again, that's more that perimenopausal state. Men, actually, this society recommends men age 70 and older. And then men less than 70 with the risk factors. Any adult with a fragility fracture. So if we're seeing patients either in the hospital or at our office that's had a fracture that we would consider a fragility fracture, we really need to make sure we know what their bone density is. And then adults with disease or condition associated with low bone mass, of course, and kind of there's a couple other things. I will say, you know, their recommendation to screen men 70 and older doesn't necessarily follow the USPSTF, and thus you're not going to see that insurance is always going to cover that. So that's something to be just aware of. If you're sending someone, make sure you're identifying what their risk factors are. So how do we actually diagnose once we get the bone density results back? And what are we looking for? So when we're looking at bone density, the second slide I have here, we'll kind of talk a little bit about T and Z scores. But just to bring about, we're going to talk about T scores first. And T scores are going to have ranges, and so it's a little different to read them, but your normal bone density is anywhere from a +1 to a -1. Osteopenic bones are going to be a -1 to a -2.5, and osteoporotic bones are going to be a -2.5 to -3 or worse. Severe osteoporosis is usually worse than 3.5 or a -2.5, and they've had a fracture. So something to consider of that's like a combo to define that. And then you may also diagnose a patient with a hip fracture with or without a BMD. And so you don't always need the bone mineral density, but it is helpful to sometimes be able to monitor a given patient's kind of condition. And then here's a little bit more about what is a T-score and what's a Z-score. So that T-score that we calculate, or that gets calculated, is actually the patient's bone mineral density minus the mean bone mineral density for a young normal population. So they kind of know what that is. And then they put that over the standard deviation of the bone mineral density for the young population. So it's really comparing their bones to young, normal, healthy bones. A Z-score, on the other hand, is actually comparing their bones to age-matched group. So, you know, they're going to look at every 65-year-old, if it's a 65-year-old, and have that. And so the Z-score is more comparing to age match. You don't see as many recommendations really coming out around what the Z-score, what your management is. It's mostly T-score that helps you with management. But I wanted to show you kind of what it's going to look like. Your image is going to usually show some pictures a lot of times, and then where they've calculated and what they've calculated. This is just an example, not exactly obviously what ours looks like when it comes through. And how do we manage osteoporosis? We'll talk about actual treatment, but ahead of time, if we can get people doing some of these things, they're going to have less likely chance of developing osteoporosis. So again, I mean, I saw a well woman today, and we talked a lot about this and just what is she doing for her nutrition, what kind of exercise, kind of what's her routine, if she has any habits, of course, alcohol or smoking, if we can cut back or quit those habits. And then is she taking any extra supplements, you know, vitamin D, calcium, etc. So trying to get a woman thinking about her bone habits and about her bone density ahead of time is actually really important. What I've seen stated in literature before is that we develop and we kind of build bone density up to the age of about 35. And after that, then our bone density basically, you know, it can be maintained, but it also can decrease. And so I always kind of tell my patients that we're like working on, we're moving up the mountain until we're 35. And then if we've built our mountain high enough, the good news is that there's a lot more to come down from that mountain. But if we haven't, then unfortunately we get to osteoporosis a lot quicker. And so getting your young women, both your teenagers and your young females in their 20s and 30s, to do some of these healthy things to make sure they're getting enough dairy and calcium intake and vitamin D intake is really, really important because we want to build that mountain as high as possible so there's less chance of them coming down from the mountain. This is a nice table that I felt was helpful, and I will be putting actually this table as well as the main article that I took this talk from in your mailbox. So we'll do this after the talk so you guys have this reference table later. I know a lot of times we look up stuff too, but sometimes it's nice to just have a paper reference of management. So we're going to talk more about like both risk assessment and then what do we do when we've assessed the risk and they do need something, and kind of what are our options. So the biggest thing is trying to optimize their lifestyle and making sure that they're getting adequate nutritional intake of calcium and vitamin D. And then doing the risk assessment with that FAAFP tool is really helpful. So we can then get a better idea of where they're at. If they fall into that low or moderate risk bucket, then they just need the low risk, really just, and both of them really just need risk assessment every 2 to 4 years. So, you know, when they're in for their well woman, you know, kind of redoing that FAAFP tool every so often can be helpful in making sure that they are still staying up with exercise and good diet habits. If they fall into the high or very high risk, then we need to start thinking about treatment and what we need to do for them. And so this is a nice kind of quick summary of what to think of and what our options are. I also will have a table here in just a second that kind of goes through each of the meds and what we're thinking of as far as that goes. But the big first start is usually bisphosphonates. They've been around the longest. They have good evidence to both prevent vertebral and hip fractures, so that's important. And they have some fairly good safety efficacy behind them too. So some of the newer ones have slightly higher risk for certain conditions, and we'll talk about those. But making sure that bisphosphonates are usually the first go-to med. And so that's like Fosamax, Actonel, Boniva. Those are the bisphosphonates that we're going to consider using. And so once they've started on the bisphosphonate, usually you're going to try to keep them on for a, you know, if it's an oral bisphosphonate, they recommend about 5 years. And so then you're going to be reassessing their fracture risk in about 3 to 5 years. And so they say 5 for oral, 3 for IV is kind of what's been recommended in the literature. And so at that point, if you've assessed their fracture risk and now they're actually at the low to moderate range risk, you could consider a drug holiday. And so that's kind of a big idea for these type of meds. That these meds are likely not going to be something that our patient's going to be on for life, but they're going to be on for a period of time. And so if they've kind of reduced their risk, then they're often able to come off the meds. And then we just do, again, kind of reassessment as part of our well woman assessment, reassess her risk in the 2 to 4 range. If they stay high risk, then we would likely consider that staying on that therapy or possibly switching to another therapy because unfortunately they may not be benefiting as much from the bisphosphonate as we had hoped. And so that's where we would consider one of the other options for them. There are going to be a large group of women that bisphosphonates are not tolerated though, because you do take them on an empty stomach and you also a lot of times that causes a lot of stomach upset. And so if they are intolerant to that therapy, then we need to start thinking about what are our other options. And those are either possibly the denosumab or the paratides, basically, could be options. And so that's why there's kind of some circular action here. If they're not able to tolerate, you may consider one of those. There are patients that sometimes can't tolerate either of those, and then we have to kind of think about whether they need.
All right.
Thank you very much.
You're welcome.
Think about whether they need further assessment for other types of meds. I'm not going to go into lots of details about the SERMs and some of the hormonal therapies, but for some of our patients that aren't able to tolerate kind of the traditional osteoporotic drugs, they may be better served with some of those. The challenge is, and you'll see this in the article that I'll give you guys, that they don't really have as much evidence truly behind preventing fractures. And so that's a challenge with the SERMs. They can be good medicines to some extent, but they're not going to really have as much evidence behind them as true fracture prevention. So, but again, to some extent, we need some of our high-risk women to be on something, and we know that there's going to be some benefit from being on those meds. Again, if they've been put on something more like denosumab, that reassessment is then every 5 to 10 years. So it's a different action for the med, and that med is assessed, you spread that out a little bit. And so again, they recommend a holiday if she's decreased her risk, which would be great, and then reassessing a little more frequently. And if she's had any loss, she needs to restart therapy if she's been on that med. And then a high-risk patient who stays high risk, unfortunately, on that med would consider, again, switching to something different or continuing that therapy. And so the biggest thing that came out of the article is really when we're thinking of starting someone on a therapy for osteoporosis is thinking of these 3 questions. First, thinking of where is she having the bone mineral density the lowest in her body, and what's the highest risk for fracture for her? Is it her hips, her vertebra? And so knowing that can really help you decide on a medicine, because there's some data on a couple of them that are definitely better in certain areas of the body. And so we'll look at that chart here in just a second. The second question you want to ask is there any condition she has, or she or he has, I guess, that would interfere with therapy? So difficulty swallowing, any esophageal condition, or GI irritation, because unfortunately these meds, especially the bisphosphonates, are often linked with like a severe esophagitis. And so we would not want to kind of start that in someone who already has trouble. All bisphosphonates are contraindicated with hypocalcemia. So getting a baseline CMP is a good idea. And that's something to also remember if you've not gotten one in a patient recently when you're starting those. The third question you want to ask yourself is, does the patient have any issues that would prevent adherence? I think that's a funny question, because I think we all have issues that would prevent adherence, but for some patients, they're maybe going to be less adherent than others. And so adherence may improve, though, if you're able to do a med that's spaced out more. So there are definitely some that are dosed weekly, some that are dosed monthly, some that are every 3 months, and some that are annual. And so again, that may be something sometimes that we have to convince the insurance that they need. But if there's definite need because she's high risk and she's not able to take something weekly, or is not tolerating taking it weekly but could do a yearly shot, then that might be something that we can get her. So this is that table. We're not going to go through these details, but I wanted everyone to see it, and this will be in your mailbox. And because this article was really good at summarizing both what the dose would be, what that vertebral fracture risk and hip fracture risk, how much they decrease that risk. And so, and then any additional comments, because each of these meds kind of has their own set of adverse effects that we want to know about to make sure that we're putting the patient on the right med. So definitely one size does not fit all for these meds, but I think taking a look at this, and you can pull a lot of this information from Hippocrates or one of the others, but I like seeing it all in one table. It's a lot easier to kind of process. The biggest question I think we see is really about duration of therapy. I know here in the clinic, because you guys share patients and patients get a new doctor every 1 to 3 years, unfortunately, sometimes the consideration of how long they've been on a given medicine is forgotten a little bit. And so we do need to be aware that if we're seeing patients on bisphosphonates or any of the osteoporotic drugs, we want to ask how long and when was the start. See if you can look back at pharmacy records and see when she first started getting that med, because we don't want these meds to be used indefinitely. And so this is not a med she's going to be put on until the end of time. And we want to make sure that she's had a possible drug holiday, because a lot of times that can be helpful knowing whether she's going to need this med for a longer period of time. So the ACP actually recommends that you do 5-year treatment. And really their statement is that that's probably all most women need is 5 years. Whereas the American Society for Bone and Mineral Research Task Force recommends that you review the therapy after 3 years with the IV bisphosphonate. And so that's where that newer recommendation is, to look at the 3-year mark for IV and the 5-year mark for oral. There have been two newer trials out that looked at duration of therapy that actually went longer than those times. And both of those have shown some positive effect. And so now there's a little bit of a debate about whether we need to consider keeping women on this like longer than 5 years. And so I don't know that we're going to see any change yet in recommendations, but that may be coming. And so something to be aware of. But the bottom line is just really reviewing what therapy they're on and what they've been on in the past possibly too, and then making sure that we're possibly considering taking them off the med and doing a drug holiday, and then monitoring their bone density. So there are some adverse effects to these meds, as I mentioned before, and the big two that we want to be aware of is the atypical femoral fracture, actually, and this can occur when we use extended use of bisphosphonates. So that's why the drug holiday has definitely been favored when we're using bisphosphonates, especially if a woman is low risk for fracture. So we want to make sure that we're giving her a break off the meds, because this has been shown to be a risk for some women. So just being aware of that again, when she started, when she ended. And then osteonecrosis of the jaw. I think that was one thing that was in the news a number of years ago as a scary side effect or risk factor for these meds. And so it's associated when we have someone on a higher dose or higher potency drug. And then the longer they're on it, and if it's given IV, there's a higher risk. So that's why the American Association of Maxillofacial Surgeons recommends that we discontinue this after a period, for a period of 2 months prior to and 3 months following elective dental surgery, because there has been some link when they're getting surgery that this can put them at higher risk. So if you have patients that are going for dental work, most of the time the surgeons are going to be asking about this, but if you know ahead of time and you can talk to them about their bisphosphonate kind of stop and start, that would be helpful too. And then if a long-term holiday is selected, you definitely want to still follow up. So you don't want to drop this off your radar, but put that in their well woman assessment is when their bone density needs to be assessed again. And that way, you're not going to kind of forget that they need to possibly get restarted on meds. So one of the board questions actually was in relation to treating someone who has a glucocorticoid-induced osteoporosis. So that's maybe a separate set of patients that possibly is younger, that's been taking steroids for a while. And so again, this may fall to those that are have a rheumatology condition, because oftentimes they may be on the steroid a little longer than any general population. So making sure, again, rheumatology may be doing some of this work, but I think as family docs, we want to make sure we're covering our bases too. So making sure that they are getting their calcium and vitamin D in, they are doing as much weight bearing or resistance exercise as they can handle. If they can stop smoking, that's going to be a huge benefit for them, balance their diet, and then obviously limit alcohol. big thing here is that they would benefit from treating, from starting an oral bisphosphonate earlier. And so, that would be something to consider, is that if patients aged greater than 30 are taking very high dose glucocorticoids, so the key here is how much accumulative dose that they get in a year, that you would want to go ahead and start them on oral bisphosphonates. Definitely doing a DEXA to see where they're at is important, but they would qualify just by how much steroid they're taking. So making sure that that's something that you're evaluating and following up, because you may not be the one who's actually giving the steroids, but it's good to know how much they're getting total. And so some key points here is really remembering we need to treat our high-risk individuals, especially anyone who's had a previous fracture. Those are people that we should kind of assume they have osteoporosis until proven otherwise. And most of the time they really do. Trying to use our FRAX tool a lot more, build that into our Well Woman template, or as, you know, kind of into what we make comments about as far as their 10-year fracture risk. And then starting to consider treatment early for some of those women, especially if they're high risk. And then bisphosphonates and denosumab should be the first therapeutic choices for the postmenopausal women at high risk. And then making sure we don't forget about them. We need to reassess them every 3 to 5 years. And decide whether there's someone who needs to continue therapy or who actually could benefit from a drug holiday. And then women who are, and that's kind of drawing to that point, was women who are on bisphosphonates, making sure that they are kind of put on drug holiday just because of that atypical femoral fracture risk. And then there are some patients that they're super high risk for fractures, and teriparatide is someone or is one of the drugs that's actually best for them, because they have they've had multiple fractures possibly, or just at high risk for having multiple fractures. And so that, if you look at the table that I'll provide, that's going to be your best med for kind of covering your bases there. Definitely getting women on calcium and vitamin D, as most are not getting their amounts in their diet. So most are going to need a supplement. And then just remember to monitor bone mineral density in high-risk individuals, you know, every 1 to 3 years. So trying to build that again into your routine for your women's health when you're seeing them, and discussing anyone with those medical conditions that would be at high risk, making sure, because a lot of times we're doing so much around their chronic disease, we kind of forget to do their well woman, and making sure that we're addressing this as a risk that they need to be getting their bone mineral density done sooner. So these are the articles and kind of references I used. Like I said, I'm going to provide you guys with this last one, the osteoporosis, a quick update, because I felt like it was a super helpful article, and it provides you with the table. So we'll put that in your mailbox after this talk. What questions do you guys have? And I'm looking to make sure I don't see any chat, but again, all of a sudden my thing looks like I can't see the chat function. Oh, there we go. There's one. When we're monitoring bone mineral density, does the FRAX tool guide when to reassess with DEXA as well? I don't believe it actually says when to reassess. It gives guidelines at the bottom of the FRAX tool as far as recommendations. But if you're getting a BMD on a patient and putting their information in the FRAX tool, the big thing with the FRAX tool is putting them at really whether they're high risk and they would qualify for starting a medicine or not. And so the FRAX tool can be super helpful in your population younger than 65 that wouldn't routinely qualify for bone mineral density screening, or wouldn't routinely qualify for a medicine unless you put all of their information in together, and then you realize, oh wow, they're higher risk than I thought. And so that's when you would use your FRAX tool. Hopefully that answers the question.